I'll text you on WhatsApp because obviously I can't use the chat if I need anything.
Yeah, it's fine.
Hey guys, so we're just waiting for a couple more people to join and we'll get started. Great. Hi guys. So we'll get started and people can just start joining as we go. So today we'll be talking about joint pain as one of the key UKMLA topics that you guys will be assessed on. So today we'll be just very briefly talking about pain presentation. So when we speak about that, it's what a patient means when they say they're coming in with pain. because obviously it's quite a subjective term. Then we'll be exploring different differentials that you can come up with, how you can rule in or out some of them. And then we'd be exploring the causes of certain ones and then how you can manage with it once diagnosed. Right. Ooh. Right. So what are certain ways that pain, these are some of the ways that pain presents. So this slide was supposed to come first, but if you guys haven't seen the differentials, what are some of the common presentations that people come in with when they have joint pain? If you just put some stuff in the chat and say maybe if you're happy to read them out. As in, what do people mean when they say, I'm experiencing pain in my joint?
Stiffness.
Yeah.
Answer stiffness, yeah.
Yeah, so it could be anything from stiffness to them just feeling that the joint feels a bit warmer, feels more swollen than normal, if it looks red, erythematous, if it's just generic pain, they can't really describe it, like an aching kind of thing. It could just be bruised, it could be getting noisy, so they're hearing certain things when they're bending the knee, when they're standing up, or if it's, for example, a hand joint, pain can present with a reduction in their grip. So without further ado, the most important thing, obviously, one of the most important tools to help you judge what could be causing the pain is your history that you take from your patient. And with any pain, you would use your classic Socrates. So I've kind of grouped them into stuff that I think is relevant. So if you ask them about, okay, I have pain in my joint, which joint? Okay, so maybe they have a knee joint. And does that pain go anywhere else? So yes, it radiates down my foot. Then that gives you a more characteristic nerve root-like pain. Whereas, for example, if they tell you, okay, I have a pain in the side of my hip, and it stays there, and they had maybe a previous history of trauma, which again brings you to next questions, then that helps you maybe think, ooh, it could be a bit more muscular in nature. Equally, you want to ask them about their onset and how long it's been for. So when you first felt that, how long ago was it? How long ago have you been experiencing this? And whenever the pain, and does it come and go? Is it always there? When you first experienced it, has it been sudden? Does it gradually build up? Do you think anything has caused it? This is a very, very, very important question when it comes to orthopedic examination, because more times than not, it's trauma in orthopedics, so it might be caused by trauma. So asking this question is very relevant and will give you an idea. Again, different sorts of injuries are likely to result in different pathological presentations. So, for example, somebody who's had an elderly who's been taking bisphosphonate presents with a fall. They are more likely to have a neck of femur fracture. Bisphosphonate is a risk factor. They're elderly, and again, they'll present with that externally rotated, shortened limb. So certain stuff like triggers help you. Equally, if someone has an injury after stabilizing, or like stepping on their foot and rotation, you're more likely to suspect an ACL-like injury. There and then, the joint's swollen up, they're not able to walk anymore. Again, ACL injury. You might want to ask them about associated symptoms. So, for example, do they have any stiffness with it? Have they experienced a temperature? Temperature is a very, very important one you want to be asking them. And not just about whether the joint itself feels warm, but whether they've had a generic temperature, because that could help you rule out a red flag like septic arthritis. You also want to ask them if they had any, for example, any white appearing nodules, which we would call as tophi, which might point you towards the direction of gout, which is caused by an increase in your uric acid, resulting in these stones building up. We'll discuss that again in more details. And then you want to ask them as well about the character of that pain. How does it feel? Is it just always there? Is it pressing? How severe is it? This is a question that people really like. And I tend to try and ask it early on, how bad is the pain? And then to build on from that, exacerbating and relieving factors, you just also say, have you done anything that makes it feel better? And then I link it back to severity. So for example, if they say painkillers make it better, I would ask, okay, so if it's normally a 6 out of 10, how bad would you say is actually the painkillers? Just because it helps you assess the degree of control of symptoms and helps you decide, for example, as a junior doctor, if you need to prescribe them more painkillers or if it's still affecting their quality of life. You want to ask them as well if it's better or worse, for example, on movement versus on rest, if weight loss helps it. And this helps you, again, rule in or out risk factors. So you're asking about exacerbating relieving factors, not only to help you with symptomatic management, but also to help you narrow your differentials. So, for example, if it's relieved by weight loss, it's most likely to be osteoarthritis. If it's relieved by movement, it's more likely to be a rheumatoid or an inflammatory condition. If it's more relieved by rest, it's more likely to be osteoarthritis. And again, we're going to talk about those in more details in a second. Right, examination, very briefly touching on to this. With any orthopedic examination, you have your look, feel, move. You're going to look at the joint. Is it red? Is it swollen? Any deformities that you can see? When you feel the joint, you're mainly feeling, is there any heat, any fluid? And you can do your special tests to assess for your fluid in your joint. And then you can also assess while you're moving their joint, or if you're feeling their joint, is there any tenderness? Is there any pain? With your movements, you want to check their range of movements, and you want to do that on active and passive movements. Passive movements and active movements is a very good discrimination. So active movements could also tell you about their muscle strength or how much the patient's able to do. If they're unable to tolerate passive movement, this could be purely due to pain, but it also tells you, again, if something is stuck in the joint or if not. So doing them both shows you two different things. And then you can do your classic specific tests. So your ACL, PCL, any, for example, tibial lag, any valgus varus tests for your collateral ligaments, that kind of thing. And then with orthopedics, what's really important is you have to do a systematic examination. Look at other joints, other body parts. So for example, if you look at their nails, this might point you towards a specific pathology, ears or skin. So skin, for example, inflammatory pathologies like rheumatoid arthritis or SLE might manifest in the joints as well as the skin. So it might tell you it's more of a systematic issue rather than that joint. Maybe ears, you'd be looking for like the tophi, like we said. So again, buildup of uric acid hinting towards gout. If you're looking at their nails, again, maybe like something like psoriasis or arthritis linked to it. So it's very important to make sure you quickly screen for other body systems as well. That, and also because, especially if it's been trauma, you want to make sure that you don't miss other injuries. So a lot of the times, traffic accidents that comes, I'm currently based in Sandwell, that present to trauma and orthopedics will present with like a knee or a hip fracture. But more times than not, they will miss a rib fracture that will be identified on a scan. So it's really important to make sure you're doing a secondary screen, especially in cases of trauma. And also, if you say that to your OSCE examiner, they'll be very impressed to see that you're looking at the thing holistically. Investigations, we're going to split it into our bedsides, bloods, imaging, and specific tests. And again, this is a very helpful way for your OSCEs because A, having a systematic approach helps make sure you don't miss anything. And B, having a systematic approach shows the examiner that you know what you're talking about and makes you look a lot more confident and well put. Right. So we're going to be very quickly doing 4 main presentations of joint pain, and we're going to be doing it in a case-based scenario to help you guys get OSCE practice in as well, see how these conditions present, and helps you guys, I guess, get more of a clinical perspective. So we have 4 people who've presented to the orthopedic clinic or to the orthopedic department. They've been referred by A&E, and one of them has been referred by GP. So Wendy Reiter, she's a 34-year-old female who's presented with sudden onset severe pain in her left knee. Ronnie Reeder is a 56-year-old male who's presented with a severely painful, red, stiff, swollen left toe. Calvin Kerner is a 67-year-old male who's presented with an increasing pain in both knees and hips. And Abby Author is a 32-year-old female with swelling in small joints, hands, and both knees. I'll let you guys have a very quick look. Maybe think of, based on what knowledge you already had, if you can come up with any differentials based on everything given. And we're going to get into the cases. So you guys have a minute. You can quickly look, maybe write down certain things so this is how your OSCE might come. A 34-year-old female is presented to the A&E department with XYZ. So you have to think, what questions would you ask? What could be in that station? What would you need to maybe interpret? what differentials you'd have. Top tip for OSCEs is write down your differentials on a paper, because it helps the examiner see that you have focused questions, and make sure the red flags are on that list of differentials, so that when you also have it on the paper, you're more likely to remember to exclude it. And again, it's something that examiners do look out for. So yeah, so have a list of differentials and make sure you put in any red flags for either of them, and what questions or investigations you do to rule them out. Case 1. So we have the 34-year-old woman. She has a background. So you ask her a bit more of questions. She tells you she has diabetes. She's been having a 3-hour episode of severe pain in her left knee. It was quite sudden onset and had very severe stiffness. She now has fever and she's shivering, you notice. She says that one day, you ask her a couple more questions, and she tells you that one day ago she twisted her knee and scraped her right elbow after falling onto ice. So you examine the patient. You look at the patient. She appears ill. She feels ill. She feels sweaty. You ask the nurse to kindly do some obs for you. Her pulse is fast, 110. Her temperature is 39.3. She's unable to move her right arm, left leg. They're both very tender, red, warm, and swollen, especially her left knee. She has limited knee movements. She has a skin abrasion over her right olecranon, and she has a swollen, warm and swollen right olecranon bursa as well. Okay? This is how her knee looks like. At this point, what are you guys suspecting? If you just drop down some answers in the chat. And then Sai, if you're happy to maybe tell me what they're putting in the chat, please.
Someone said septic arthritis or sepsis.
Okay. So that's how her elbow looks like as well on examination. So it's obviously quite red, swollen, bursa looks very inflamed. So you do a couple investigations. You've sent your bloods, they've come back. You have a raised white blood cell count with 90% neutrophils. You aspirate your joints and you get 30 ml of fluid from your right shoulder and 50 from your left knee. You have raised inflammatory markers. So your ESR is 98, CRP is 238. The x-rays of both joints were unremarkable. You do a gram staining and it shows you a gram-positive cocci. The culture of your synovial fluid shows Staph aureus. So this obviously confirms your suspicion of septic arthritis because the joint fluid, so that's your key diagnostic one, the culture of the synovial fluid. So it shows you Staph aureus. And just out of interest, this is how your normal joint fluid would look. And this is how it would if it's septic. So it's a lot more viscous and sometimes darker in color. So generally, these are different presentations of the joint fluid. This, I'd say, is probably the most normal. Some people present with this as well. This is much more cloudy. This one has bleeding in the joint, and this one clear sign of inflammation and infection and pus. So these two could be septic arthritis presentations. This one's obviously much more advanced, and this one's bleeding in the joint, so what we call hemarthrosis, and could be a sign of trauma. So first case, you diagnose her with infective and septic arthritis. It's the inflammation of the joint caused by an infection, usually a bacteria. It's very common in children and elderly because obviously they're more likely to be immunocompromised. And this woman had a breach of her skin barrier. If you guys remember, she was skating and she fell. She's not immunocompromised. But, extremities of age is another risk factor, but she doesn't have that either. Any underlying inflammatory arthritis, again, especially that they would probably be taking immunosuppressants, so that puts them at more risk. And then any sorts of joint replacement, because it could be an infection in that new or prosthetic joint, which introduces the infection into the joint. So if you think about it, you can divide the risk factors into either cause. So causal factors is a breach of a skin barrier, joint replacement, for example, or immunosuppression. And immunosuppression could be because, for example, they're having inflammatory arthritis and they're taking medication for it, they're just either very young or very old, so their immune system isn't as strong, or immunosuppression for any cause. For example, they're taking chemotherapy or any other, or like they have any, for example, reduction in their white blood cells, or for example, any other, for example, HIV, any other cause of immunosuppression, pretty much. And there's obviously a couple of causes that can introduce infection into that joint. So it could be, for example, via the bloodstream, so an infection elsewhere which travels to your joint. Or it could be from a skin or tissue infection. So like this lady, she had a fall and hence it slowly transferred into the joint. It could be directly into the joint. For example, if somebody is taking an intra-articular injection, so usually within the joint, especially if she has a history of osteoarthritis. And then it could be from a bone infection, so osteomyelitis, that then becomes septic arthritis. This is very important, and this is the reason that septic arthritis is a medical emergency. Key one being bacteria can spread to your bloodstream and result into a widespread systematic sepsis, and which can eventually become a septic shock. Obviously, this has a very high risk of morbidity and mortality, so you want to manage it ASAP. It might come to the skin surface and create a sinus. It might have a joint destruction as well, because obviously the bacteria starts destroying the tissue and can spread into the bone if it's not already from bone, so resulting in osteomyelitis. It can, again, obviously mess up with the bone function, so stimulate excess bone formation, resulting in the joint losing its function. Because obviously more bone forms, it's harder for them to, for example, use their knee joint or hip joint, whichever one's infected. So functions gradually being reduced. So this is a septic arthritis joint versus a normal joint. And of the times there's not much x-ray findings, but this one is if it's quite advanced. You'll notice a lot of joint space, there'll be erosions, reduction in the radial opacity of the x-ray, and you get new bone formation, again, very, very advanced at that stage. Right, any questions for case one before we move on?
Nothing in chat.
Amazing. Right, if you guys have any questions, feel free to drop them while I'm explaining, and we'll address them throughout. Right, so your second case is your 56-year-old man with a background of hypertension. He tells you he's a binge drinker and that he woke up with severely painful red and stiff swollen left great toe. He's had 4 previously similar episodes, but this one's been really bad and he now can't sleep, especially if the bedsheet even comes in contact with the joint. You examine the patient. He appears very distressed and in so much pain. Your nurse, again, has very kindly been very, very efficient and agreed to do your observations. His pulse is 120 per minute. His temperature is 37.5, so almost normal. However, his joint itself has a very high temperature, so it's swollen, red, and he has swelling up to the ankle. He also has a bit of a hot, swollen, and red left knee, but nowhere near as much as the toe. And patient cannot even allow you to test his joint movements, neither passively or actively. You can also do, you're very efficient, so you do an entire systematic examination and you notice there's nodules of tophi, on his ear. That's what his toe looks like, and the swelling is up to the ankle. Okay. And that's how his ear looks like. Okay. So given these two, what do you guys think is the most likely presentation?
They're saying gout, or 3 of them said gout and 1 said pseudo-gout.
Okay. Amazing. So you do a couple of investigations to help you distinguish between gout or pseudo-gout. You realize that they do have a raised white blood cells, but and their serum uric acid levels are quite high. You aspirate their left knee. The gram staining shows you there's no organisms, so you rule out septic arthritis, which is, again, something that a lot of OSCE examiners will expect you to rule out and make sure you have on your list of differentials for anyone with a red, swollen, painful joint. You then do polarizing light microscopy, which shows you needle-shaped crystals that are birefringent. This is typical of uric acid accumulation. So, for those of you who aren't sure if it's if it's gout or pseudogout, what do we think now? What has this told us? So typically a buildup of uric acid, needle-shaped crystals, possibly birefringent, is characteristic of gout, and that's what they look like. Quite needle-shaped. Right. So gout is a crystal-induced arthritis because of the deposition of uric acid, which is the chemical that's actually responsible for it, is monosodium urate. It could be mono or polyarticular, so one joint or multiple joints. Usually tends to become polyarticular and symmetrical later if not managed properly and promptly. There's different types. You have the primary one, which is idiopathic, so it doesn't really have a specific cause or is usually just because of a kidney, because of some issue with the kidney, and tends to have a family tendency. Secondary, however, is because of an increased production of uric acid or a decreased excretion, so usually caused by a drug or a disease, like there's something specific that causes it. And then if an increased one, for example, would be alcohol, which she told us he's a binge drinker, or a high purine intake, so someone who's typically a meat eater, red meat eater, or for example, certain things that increase high turnover of cells and hence resulting in uric acid production. So for example, treatment with certain chemotherapeutic agents. Right, so pathological changes that you'd expect to see on an x-ray for gout. So you'll have some soft tissue swelling, which is quite evident here, especially in the big toe. You can have erosion, so can you see here the opaque parts? Sorry, yeah, the darker bits. And then you can have tophi. You can see them over here. And some people might confuse this for malignancy, which is why having a history and the right investigations is very important. This is how it would look like if not controlled properly. So it starts going to multiple joints. As you can see, there's tophi, multiple areas. You get this deformity, and now it starts to include multiple joints instead of one. Right. That's our second case done. Any questions before we move on to the third one?
Can't see any questions.
Amazing. Thank you, Sire. Right, and then our third case, we have the 67-year-old woman who's overweight, 15-year history of increasing pain in both knees, hips, neck, lower back, and finger joints. It's been intermittent swelling of her knees and fingers. Symptoms tend to become worse after activity. She's stiff in the morning for 5 to 10 minutes. You do an examination, you see that her vital signs, nothing remarkable. She does have a bony enlargement of some of the finger joints, specifically proximal and distal phalanx. She has a full range of movement in all joints, and she has some crepitus in both knees on movement. So this is what her joints look like. Oops. Okay, so what do we think given the information we've been told and how her joints are looking? So she's 67 years old. Sorry, you go.
Yeah, some answers. OA, swan neck deformity. OA again. Yeah.
Okay. So this is something that took me a while to get my head around, but swan neck deformity and Boutonniere's deformity are both characteristic of rheumatoid arthritis. And the difference is in either swan neck or Boutonniere, which is rheumatoid arthritis, you will get flexion of one of the joints, of either this, an extension of that one, or the opposite. In this case, they're both the main characteristic thing is the nodes or the swelling in the joints, as you can see. You can't see flexions versus extension in either joint. So it's all kind of flexed, relatively symmetrical, and it mainly appears flexed because of the nodes. And this is what we call Heberden's and Bouchard's. So how I thought of it, Bouchard's is a B, it comes first, it's more proximal, so Bouchard's and then Heberden's. And these are characteristic of osteoarthritis. And that's what your x-rays tell you. So your x-rays, sure, yeah, there we go. So your characteristic x-rays will show you narrowing of the joint. You will see osteophyte formation. You will see some spiking if it's in the knee, and you will see narrowing. How I think about it is loss. So loss of joint space, osteophyte formation, sclerosing of the joint, which I'll get into in a second. And you'll get cysts, subchondral cysts as well. So here are your subchondral cysts. And your subchondral cysts basically happen because of the wear and tear of the joint. So it creates crack in the bone. So a crack happens here, for example. So synovial fluid comes in from here and it gets entrapped under the bone. So this results in your cyst formation. Sclerosis, on the other hand, is when the bone rubs against each other so much that friction basically encourages more bone formation. And when more bone forms, it appears more dense on the x-ray, so it appears white. So we call this as sclerosis. And then osteophyte formation is just basically where this bone generation isn't just in the site of the cartilage, but it's to the sides or between bones. So it's quite an abnormality. So sclerosis is the same shape, it just appears darker, whereas osteophytes is completely new bone formation in areas it shouldn't be. So like here. And again, that's all your body's reaction to friction or an increased weight loss, because obesity, is a key risk factor for osteoarthritis. Right. Any questions about this case before we move on?
No questions.
No questions? Sorry, Sai, did you say no questions?
Yeah, no questions.
Oh, okay, amazing. Okay, fine. Moving on to our next case then. This one is a 32-year-old woman. She has a 6-month history of pain and swelling in her small joints of both her hands, and knees. She gets stiff for 2 hours in the morning. So in comparison to our other lady, she is stiff for quite a long time in the morning when she hasn't moved. She tells you she's been feeling in the dumps, and she says that she's lost 3 kg in the past 2 months. Weight loss in general in medicine we tend to think of as a big red flag, especially if it's not over a long period of time. 3 kgs in 2 months isn't that bad. 3 kgs in 1 month, I'd be a bit more concerned, but I generally get a bit more concerned if it's 5 kgs in a month. That's when I start thinking, should I be thinking a bit more? So she's lost weight, but not enough for me to think, oh, it could be a malignancy or that she's severely unwell or something very, very serious could be going on. So you examine her. Her vital signs are unremarkable. She has both her knees, wrists, MCPs, interphalangeal joints of both her hands are very tender if you touch them. They're warm, they're swollen, and they're slightly red. That's what her joint looks like. So you do an investigation. It shows you she's anemic, which is like half the population, but normal white blood cell counts. Her inflammatory markers are raised. So her ESR is 80 and her CRP is 35. What are we suspecting?
Fibromyalgia, rheumatoid arthritis.
Okay.
Yeah, a few more for rheumatoid.
Okay, amazing. So it is rheumatoid arthritis. And just to quickly respond to fibromyalgia, it could very well be a presentation of fibromyalgia, because fibromyalgia is by definition 8 or more of certain joint site pains. But because she also does have a lot of clinical features that are explained, you're more likely to diagnose her with rheumatoid arthritis rather than fibromyalgia. So rheumatoid arthritis is a chronic cause of joint pain, and it usually affects 1% of the population. It's more common in females than males, and it tends to typically happen between 35 to 45 years of age. And our woman in this scenario tends to be right within that category. So it's usually symmetrical, multiple joints, widespread joint involvement. It usually starts with the small joints, but it can also involve medium and large joints, and that's when so small joints is classically your fingers, toes, medium and large is knees, shoulders, and above. It may be associated by other non-articular disease. So for example, it might be it's a very common association with SLE, which is why it's very important to do your systematic examination. In this case, it was normal, but a lady who presents maybe with polyarticular, so multiple joints hurting, has a butterfly rash, has skin manifestations, you might want to think, ooh, does she maybe have SLE? A raisin, for example, ANCA, or other inflammatory markers, you might want to think, okay, it could be something else. You also want to consider other pathological changes that could happen. So you could get synovial hyperplasia. So because it's inflammation, your synovium might react by, again, multiplying to react to that, resulting in pannus formation. So that's like soft tissue basically formation, which gives it this classic swollen appearance. Usually it's a bit redder than this, to be honest. But yeah, you can also get invasion and destruction of cartilage, again, because of that inflammatory cells attacking your cartilage. And finally, you can get focal destruction of bone. So you can get erosion. I love this table, and I think it's made my life very different. For those of you struggling with MCQs, this table is something they love referring to in MCQs. So typically, obviously, osteoarthritis would have higher age of onset because it tends to be a wear and tear situation. So obviously, the more you grow, the more likely it's going to be osteoarthritis problem. If it's their pain, usually with osteoarthritis, it's a case that the pain is usually worse during or after their activity, whereas in rheumatoid arthritis, it's worse in the morning or after inactivity. So in summary, here activity makes it better and here rest makes it better. And if you think of it logically, osteoarthritis is the wear and tear of the joint. So the less you use it, the less pain you'll be in. Rheumatoid, however, is inflammatory cause of the pain. So the more you move the joint, the less the tissues are in contact and the less you're allowing that inflammation to settle in. So the better it is. In terms of stiffness, they'll usually describe short period of stiffness in the morning, whereas they would usually describe a longer period of stiffness in the morning. And remember, we said that stiffness could be a presentation of pain. So these people don't like inactivity. So they'll feel more stiff if they haven't been active for a long time, aka when they wake up. Whereas these people will feel better. So their stiffness wouldn't be as much. Joint characteristics. So here you'd have more of a hard and bony. As we discussed, you have your Heberden's and Bouchard's nodes. Here it's more likely to be soft, warm, and tender. The minute you feel their interphalangeal joints, they'll be flinging of pain. Whereas here it is just going to feel hard. And again, just building on from that point, jumping into the Heberden's nodes and Bouchard's nodes. So the Heberden's, like we discussed, is the distal one, and Bouchard's is proximal. Here you get your Boutonniere's, swan neck, and ulnar deviation. And then lab findings here, normal rheumatoid factor, normal anti-CCP, and normal inflammatory markers, whereas here everything will be positive or raised. Again, I didn't put these obviously in because I thought it would literally give you the diagnosis, but yeah. Primary joint effects is obviously not a rule of thumb, but this one tends to be more small joints and then becomes ankle, elbow, wrist. This one more so the DIPs and then thumb. So classical presentation of squaring of the thumb. You'd read it in MCQs, but be careful because sometimes here it can also present with squaring of the thumb. So it's not necessarily characteristic. So this is your classic sign for one of them. Can we pop in the chat what this sign is called and which condition it would be associated with?
They were an ulnar deviation.
Mm-hmm. Yep. Yep. Amazing. So, yes, this is ulnar deviation, which is characteristic of rheumatoid arthritis. The other thing that's characteristic is X-ray findings. So a lot of the times, because of the inflammation, you get fusion of your wrist joints. You can get a displaced thumb joint, which gives it the classic squaring appearance, which again could be the case of osteoarthritis. So it's not necessarily discriminatory if you see a square thumb. You get destruction of the joints. It looks quite swollen, high intensity, eroded. It's not normal. So it's either very swollen or just very eroded. So you can see it's not like your classic joint that you'd expect to see. You can also get your deviation of the fingers. So obviously it starts to deviate towards the ulnar side. So yeah, these are our 4 cases. So today, obviously, we've spoken about the different ways people can present when they speak about pain in their joints. We spoke about different differentials or the key differentials that could come up in your OSCEs or MCQs. We've spoken about the causes and how you can manage them and certain characteristic things for each of them that will help you deal with them accordingly. So yeah, thank you guys for coming. This is the feedback form if you guys want the slides or recording. And we have a session again tomorrow for acute urological emergencies by Dr. Hassan. It's tomorrow at 7 p.m. and this is the QR code for you guys to join. So yeah, this is your feedback form for the slides and recording, and this is your sign-up form for tomorrow's session. Thank you guys for coming. If you have any questions, feel free to email me. Thank you. And if anybody has any questions, of course, please feel free to pop them in the chat. Right, I'm gonna stop sharing my slides. I hope everyone's gotten access to this. If you haven't, please feel free to check our medal page where we can get you. So, okay, I can see some people are saying feedback link. Okay, I'll send that in the. Okay, Sai's already sent. Amazing. Thank you so much, Sai. Right, thank you. You guys are very welcome. That's okay. It's off anyways. Okay, I'm gonna just end the webinar there because people will still have access to the chat. Is that okay with you, Si?
Yeah, people still have access even if we leave. Yeah.
Amazing. Right, thank you so much for all your help.
Yeah, no worries. Thanks, guys. See you later.
See you. Bye.